All right, I'm back for this light, right? I had to switch phones and it's a little weird. I don't know why this phone screen makes me look like I'm a lot darker. So I don't know, maybe that's just the camera. Anyways, I hope it's not too dark. I don't know how to change it on this phone. Maybe it's just the screen. Okay, so the little unconventional this week, this is segment 2 of a 2-part talk today for Wellness Wednesday. So no, if you're just joining me, you're not going crazy. I tried to do a talk at noon. I didn't have enough time to prepare, and I ended up going on live with the first part of the talk about the pediatric inflammatory multi-system syndrome at 12:30, and then took a little break so that I could get caught up and review my notes on the second topic that I wanted to address today, rather than leave this until next week, because I think the rate at which this type of information is going to be coming out is going to start amping up so quickly that it's going to be really hard to keep up with it. So I wanted to basically give you a synopsis of the video that I watched this morning, which was about Dr. Brady, who is a naturopathic doctor who helped to create Diagnostics Solutions Laboratory. It's a analytic, high complexity lab that's mainly been serving the integrative healthcare field for the last 5 to 6 years. So the high complexity lab is the important part. That means that they have been validated and given approval to do high complexity testing, which involves molecular stuff like DNA. So genomic testing, in other words. So they were one of the first private labs to get their validation into the FDA, which was brought to my attention by an article in the Wisconsin State Journal this last week, in which they were starting to question the quality and validity of some of the antibody testing being ordered. And as I said, the first notification I got about any kind of testing came from Great Plains, which was a lab that I've used for environmental toxicity testing and heavy metal toxicity panels for patients. So I was really excited because they've offered other types of antibody testing for foods, which I don't usually get into because I do the Carroll method, which is much more effective. And I just jumped on because I wanted to be able to have this service to offer to people, because I knew how integral this type of testing was going to be in terms of understanding more of what this SARS-CoV2 really is and the clinical presentation that is COVID-19. So I'm going to do my best. Dr. Brady did an hour talk. He was interviewed for the article that's going to contain a lot of this information is going to be published in the NDNR, which is the Naturopathic Doctor News and Review, and the Town Said Letter. It's going to be coming out later this month. But again, I think this is the kind of stuff that people need to understand as you start turning on your TV in the morning and you're seeing the news talk about, oh, new testing available. The reality is that some of the testing is just not going to be available to you. And if it is, it might not be giving you what you think it's giving you in terms of results. So, Diagnostic Solutions Lab, they have been doing a lot of COVID-19 diagnostic testing, specifically on respiratory samples. So the ones that involve a swab, oral, and nasal, although he doesn't think that those are good as the lung washing samples that they're getting from the ICUs. In parallel, they also developed their quantitative real-time stool testing for COVID-19. And this was based on the information they were getting out of China and South Korea, showing detection in the stool both before and for long after detection of SARS-CoV in the lungs. So this also brings back to the forefront the possibility of oral fecal transmission and why hand washing is yet again so important. So mainly up till now, they've been just doing their frontline diagnostic work, partnering with hospitals and such. And then they brought on this stool PCR testing for community surveillance. So the PCR is the molecular aspect, the DNA sequencing stuff where they're amplifying the viral RNA to look at it. And so right now, COVID-19 is classified as a respiratory disease. Therefore, according to the FDA, the only laboratory test that is diagnostic of COVID-19 is a respiratory sample-based PCR test. So this lab can't call their stool test diagnostic because the FDA hasn't approved that as a method of diagnosis, right? But that doesn't mean it doesn't still serve a really good use here. They also waited a little longer probably than other places to get their antibody testing on the market. They wanted all of their FDA validations in. So if you don't already know, the reason that some of these antibody tests are questionable, it's for two reasons. One is that things like the PCR molecular testing, those kits and methodology have to be developed in-house at the lab. They have to have that technology there to do what they're going to do to amplify and look at the RNA and DNA. Now, antibody testing is just based on ELISA kits, right? So anybody who's ever taken molecular medical microbiology, like I have, you got to do this in lab. This is what you did, all these different kinds of tests. So the ELISA kits are manufactured by other big companies, some in the US, some from abroad, and all of the labs just use them. So you don't have to have had any previous experience doing any kind of antibody testing and be a lab that just now orders ELISA kits and says, hey, I'm going to jump on this train. So, the kits from Asia, he said, are not as good. The ones you want to make sure you're getting are from the US and Germany. They are better kits with better reagents. And the serum is better than a blood spot. So again, I know that Great Plains was talking about offering down the road a blood spot. And I was excited about that initially because I thought that would be a great option for kids. We'll get into that in a little bit, why that might not be such a great idea. So again, the clinical disease is COVID-19. The virus itself is SARS-CoV2. So in the media, these terms get messed about, and this is what further makes the testing confusing. So right now they're throwing around the word rapid testing. Rapid tests are made by specific biotech companies like Abbott and Roche and only work on their instrumentation, which means they're very proprietary, which means the facility has to have the right analytical equipment on hand to process those types of tests. They don't include PCR, so there is no amplification. There's no messing about with the RNA. So you have to have a very high viral load because you're not amplifying it. So this is only best done at the point of care, i.e. in acute medical facilities, and done on really sick people who have been sick for 12 to 24 hours in order for the kit to have enough of a viral load to get a positive result. So when you don't have the PCR step, you don't have the amplification, that's what a rapid test is looking at. I'm assuming he didn't use the word, so, take me for what you will, but I'm assuming this is what the antigen kits are doing, right? So antigen kits are simply identifying that there's a foreign agent there, right? That makes sense. PCR testing is amplifying the RNA to see that there is viral RNA present, okay? So that's the difference. With PCR, with amplification and sequencing, there's not necessarily the need for you to be sick because they're going to amplify whatever amount they get to see what's there. Okay, so some antibody labs are doing the blood spot, right? This you do with a blotter card at home. Again, his point of view on this is that it is a very limited sample and hard to work with. In other words, you're not going to be able to get the level of sensitivity that you can with a serum sample, with a blood serum sample. And that's what we really need because the whole point of this is to answer some really important questions, right? About who's got antibodies, who doesn't, what does that mean? How many antibodies, what does that mean? So, for instance, someone with a lot of symptoms that is sick with COVID-19, you might look for sky-high antibody titers and possibly IgM, and in that case, the blood spot might be okay, right? So if they're really, really sick, and you want to just do this at-home thing yourself and a lab has this available, then maybe that could be okay. You could trust the positive with that, right? The problem is there's a lot of false negatives, right? So, and again, that is all because you don't have the resolution of it, right? It's not a good enough sample. So when trying to separate those who've been exposed versus someone who's not at all been exposed, this could cause a problem. This could give a false sense of security, right? Looking to find what they're ideally looking for is to find people who have sustained IgG but no IgM. This means that you've been exposed in the past and you have some level of immunity, right? Now, we have to be very clear on this. You are not immune. Nobody is saying that. Nobody is saying that. What we are saying is there is some level of immunity, because that's how immunity works, right? That's why you get a vaccine if you're someone who does vaccines, because being exposed in theory gives you the immunity, right? But now even that we know doesn't last for forever. That's why there's booster shots, okay? So the caveat here is with antibody testing, if you have high sustained levels of IgG, we are assuming that you have some level of immunity. We don't know yet how strong that level is based on the titer levels or how long it lasts, because this is an RNA virus. It's just like the flu. It can and will mutate, which is why we don't have a static flu vaccine. The flu vaccine changes every single year, okay? However, as a coronavirus, which we have history of other infections like SARS and MERS, we assume with best intentions that immunologically this virus will react the same. Therefore, it's likely if you have IgG titers present in your blood, you will have a certain amount of sustained immunity for a period of time. How long? We don't know. Only time will tell. We're only ever going to know this once we look back at this completely retrospectively, okay? So quantitative panels like what they're doing help to find the lower levels of titers to, again, look for any level of immunity. So again, this might be a false negative on a blood spot or a rapid test. So part of this whole issue where people are assuming like, oh, I'll just get this test, right? The problem is for certain types of tests, like the rapid tests, they can only load one sample at a time. It takes 15 minutes and they have to wait for 3 to 5 minutes in between. There is absolutely no capacity with that to handle the level of testing that we need to. So the PCR tests, they're sequencing, they're running 100 tests at a time, okay? So in theory, we can't test everybody with antigen testing or rapid testing or the saliva testing, which I believe is the test that just was talked about on the news the other day. So we're also getting a lot of mixed messages with the antibody testing, right? Some people are really talking them up. Some people are now talking them down. Now, initially, my own feeling with that is that, okay, they talked about vaccines, they talked about antibody testing. How are we going to get people safely back to work? Maybe the antibody testing is part of that. Well, now everybody's jumping on the antibody train. Now, oh, no, we don't know. We don't know if the antibody testing is great because we don't know what it means for immunity. So, yeah, but by default, what does that leave? Oh, the vaccine. Okay, so that's just my rant there. However, where people are running into issues now is the fact that it gets dicey, right? Because sure, there are some tests that are not as great, but even if you're just looking at the ones that are good quality ELISA kits from the US or Germany and good quality labs, the problem is, how do you treat the groups afterwards? Just in theory, if everybody got antibody tested and we know the population that has IgG, which means they have some level of immunity, and you have a population that doesn't, which means they haven't yet been exposed, what does that mean? Does that mean we then have different sets of public rules? The way officials are looking at this is that now they're saying, well, we don't know if we want to do antibody testing because it may cause more issues inherently by treating people differently, right? And or are those who get antibody testing and have IgG titers and are confident of their immunity, are they going to refuse to follow any rules? So it's causing a lot of conundrums, right? Okay. In regard to false negatives, so the diagnostic stuff, the molecular. So we're talking about, again, the amplification, the PCR testing, where you get the swab of some kind of respiratory sample. Sometimes the false negative is not at the level of the lab, but rather the sample collection. And again, this is why there are so many issues with false negatives with this method of testing, because there's such a special technique in collecting it, in the amount of sample you need, so that even if the lab is perfect and spot on, there might be nothing present because the sample wasn't sufficient. So this is why this method is probably never going to be the one that you're going to get to do at home. It relies too heavily on the sample being properly taken, having enough there, and in point of fact, still to this date, it's they don't have enough tests to test the people in the hospital. So this is always going to be given to the acute people who present with symptoms that they are going to try to get a diagnosis for in that moment, not someone who's at home wondering, well, I wonder if I have it. According to him, aspirates and washing are the best. Again, these are only going to be done in hospitals if you're, admitted. The swabs for the nasopharyngeal, the oropharyngeal, they're all okay, but they're very invasive. They're very uncomfortable. And then obviously, like I said, the at-home samples are not going to be good at all. So those are going to be very subject to false negatives. We would be very skeptical of people doing self-swabs at home and sending them in and saying, oh, I'm fine, I got a negative. Might just be your sample was crap. So again, the saliva test from Rutgers is out now. He again says, Dr. Brady, there is a use for it, but again, it's not preferred. It's not going to be a great sample, so it's going to suffer a lot from false negatives, and it's also going to suffer from false negatives simply if the viral load is not high enough to be detected, okay? So again, best used in facilities and hospitals on the very acutely ill. So with molecular testing, you're looking for the DNA, the protein, etc. This is where the PCR is involved. You amplify it, so there's more of it to look at and work with. Obviously, doing PCR is not quicker, right? That's why it's not rapid testing. Rapid tests are really only going to be done effectively at point of care. They're not using the amplification, so they're reliant on having a lot more of the viral load in the sample. They're just looking for pathogen X. So this is not going to be a great way to find asymptomatic people, again, right? Because it's relying on, there being enough of a viral load that you would, in theory, have symptoms. So antibody testing is still going to be the way to, if someone has been infected and was asymptomatic, to look back and say, hey, well, yeah, you were infected, or you weren't because your titers aren't high enough. Okay, so the reason all of these things, though, still remain somewhat important is because there are many ways of coming at it to try to triangulate this, to pattern it, and not just rely on one marker or one test. So when you combine the diagnostic testing, the point of care testing, like the swabs with the PCR, plus the antibody testing and clinical symptoms, we're going to get a much better idea of what this virus is, okay? Our accuracy for diagnosis right now is hovering around 60% due to needing a high enough viral load for a positive, right, on some of these rapid tests and the PCR tests. However, if you combine that with antibody testing, the accuracy of the diagnosis improves to around 90%. But again, you can't use the antibody testing by itself as a diagnostic tool because the FDA said, no. Another interesting observation that Dr. Brady shared, which I think is fantastic and should give a lot of people peace of mind, is a very cheap way to monitor yourself at home. So what he said doctors are seeing in the frontline hospitals is pulse ox. So if you don't know what that is, it's pulse oximetry. It's a little doodad that you do that measures your O2 saturation, okay? How much O2 you have in your body. And the reason he's saying that the doctors are seeing this as being very helpful is because COVID-19 is not presenting as true viral pneumonia. And I have talked about, I believe it was Dr. Kyle something Seidel, and he was a frontline ER doc in Brooklyn, and he was saying the same thing about this months ago, about how ventilators were causing more damage. It's not true pneumonia. It's not ARDS. It wasn't working. It was an oxygen issue. So what Dr. Brady said is what these doctors have passed on to him is that people who come in and they're acting fine, right? But they know they were exposed and are wanting testing, their pulse ox was around 50 to 60%, which means they're 50 to 60% less saturated with oxygen than they should be. Now, given what we know about clinical presentation in this case, these people should be gasping for breath, literally like, oh, I can't breathe, right? Like this, if you have half the oxygen you need, that's how you should be responding. But part of it has to do with the fact that the assumption is if the O2 can't get in, the CO2 can't get out. And what's happening here is that even though these people's O2 was very low, they were still able to push off the CO2. So they weren't showing the typical symptoms of oxygen starvation. They weren't gasping for breath. So this is why we know the ventilators are causing damage. People are walking around like they're not sick, but when they do the chest films, they have pneumonia. That's literally what they say. There's full consolidation, full fibrosis in the lungs. And again, the typical clinical presentation in terms of symptoms would be a very sick patient, but they're basically asymptomatic. And the only thing they've got going is a low pulse ox. So you can buy your own pulse ox on Amazon for less than $10. It's a part of our medical kit. We get them in school. Super easy. You measure every person who comes in. You do their heart rate, their pulse ox, their respiratory rate, blood pressure, and temperature. It's just the basics, of coming in to see a doctor. So it's something very simple you can get at home. If you're concerned about this and you're thinking, well, how do I know? How do I know if we're all healthy and we get it and we're asymptomatic? How do we know? Get yourself a pulse ox. Super easy. This is the first time I've heard about this, and it makes so much sense, and it's so simple. I love it. You will never be tested with a COVID-19 diagnostic PCR unless you have respiratory symptoms. That's just how they're dealing with this right now. They have to reserve the tests for the hospitals for the people who are presenting with the respiratory symptoms. So if you're curious at all about getting yourself tested, it's going to have to be one of these other methods, either the stool PCR, if you think you're acutely sick, and or the antibody testing, okay? Some of the examples he gave was in theory, okay, this is how this is supposed to work. You're exposed, your PCR test, your swab is positive, you wait your 2 weeks, you get another test, you're negative, everybody's hunky-dory. Here's the problem with that. He's already seen patients where they had the swab, it was positive, they had the clinical symptoms, okay, fine. They stayed at home for 2 weeks, and in order to go back to work, their employer said, you have to be 14 days out from a positive test, 7 days out from symptoms, and repeat the swab and get a negative. The problem was, after 14 days, on the NP swab, the nasopharyngeal swab for the PCR test, the viral load was enough that it made it just past the point of cutoff, and they were still deemed positive. Okay, but then 4 days later, that viral load was low enough that the same NP swab test, when repeated, was negative. And furthermore, because they were curious about this case, they also did the stool analysis, because we know it can shed through stool, and we know there's limited data on that, but they were positive there several weeks later as well. Okay, and that's because even after a person is asymptomatic, that person could be shedding up to 48 days, up to 5 to 6 weeks, depending on the viral load they started with, okay? So again, how are you going to determine who gets to go back when based on what test, when they're all looking at different things and they're catching the infection at different points? So the PCR is a positive or a negative. It's not quantitative, right? It's not looking at how much, it's just saying it's there. And there has to be a minimum amount there for that test to be positive. So if you are infected and you do your test too late, it will give you a negative result, right? Because your load isn't high enough. You're already on the downslope. But if you do the antibody testing, you would see that your IgM titers would start to go down and your IgG titers would go up, because that's the immunity that your body is trying to build. So COVID-19 diagnostic testing does have to be validated. This is the important thing, okay? Authorized through the FDA. There is not one single lab that is FDA approved, okay? This gets tricky with the vocabulary. Nobody has approval. What everybody has is authorization, okay? In this emergency situation, the FDA has got what they called EUAs, emergency use authorizations. You fill this out and you submit it, and if you have diagnostic testing on a respiratory sample, you can get approved for this, okay? Now, this isn't so much an issue as with the antibody testing, right? So this isn't saying that the PCR testing is bad. It's just that all of these places would have had to submit this authorization to do this kind of test, which means they would have had to have in-house technology already to do it. So, that is not the case with the antibody testing, okay? So the EUA allowed any company that wanted to just buy up some ELISA kits and then start marketing themselves, which is why you get crappier kits, crappier labs, etc. So again, I'm checking in with Great Plains right now. I'm going to find out where they get their kits from, and I'm not super impressed anymore because I'll get to it. We'll talk about the analytical specificity and sensitivity in a minute, but one thing to talk about is that with the tests, the CDC did their own tests, right? Because they thought, we're not going to use the WHO test, we're going to do better. Well, they distributed it evenly, which was their first mistake because the virus wasn't equally distributed. And then the test had problems because the reagents weren't reliable, and they were only looking for 2 specific N proteins. Whereas with Diagnostic Solution, their molecular test looks at 4, okay? So obviously the more things you look at, the more you're going to get a better answer. So their test looks at the same 2 from the CDC, but then also 2 more proteins, okay? So the things that we're gonna ask, Great Plains, the things you wanna ask wherever you're considering getting this done is if you're gonna do the molecular test, the DNA one, the PCR, swab of any kind, you wanna ask how many molecular targets are you looking at least 4. Is it a rapid test or PCR, right? Are you just looking for the presence of something, or are you looking to confirm there's viral RNA? It's not rapid unless it's in the ICU. Those are the only places in the hospitals that are going to be able to do rapid testing, as we talked about, because they have to have special equipment to do it. So non-rapid tests, the major ones like Quest, in the beginning, their turnaround was like 11 days. Diagnostic Solutions has theirs down to 24 hours. But again, they're metering how many samples they can take in, because they're not just going to take in an unlimited amount of samples and then have them backlogged. So again, hospitals are getting priority. So you as a person at home, you're not going to be able to call them up and get this lab, right? This is partly why they did the PCR for stools. He thinks they're the only lab doing that, and they were actually already approached by some government regulatory agencies that are conducting the fecal microbial transplant studies because they want to screen the fecal matter for this. I mean, that makes sense, right? And Dr. Brady says the technology on this is rock solid. They're using the same 4 targets. They're just using stool instead of snot. So if you're really curious, this is something that I can order for you. I can't get you the swab, but I can do this, and this is safe to collect your own sample at home. There's not going to be any issue with that in terms of the proper sample, right? I mean, it's poop and you smear it. You're not sticking a swab 6 inches back to poke your brain. It's a little different. So again, back to the whole antibody testing thing is where you have to worry about, a quality lab and a quality test, so on and so forth. The ELISA kits themselves need to be a good quality, validated with an internal laboratory process. There's a lot of third-party review for this. So again, we want to make sure. I'm going to check in with Great Plains. I want to know where their kits are coming from. I want to know what their third-party review is. I want to know what their molecular targets are. If they start offering the blood spot. And I want to review their analytical specificity and sensitivity with them, because Dr. Brady says theirs is 100%. And I know Great Plains was up there. It was like 95 point something and 97 point something. But that's not 100%, right? And what he said is, from an analytical standpoint, there is 100% ability. It's the clinical specificity and sensitivity that is the unknown right now, because we don't have enough data to make any claims about that. It's novel for a reason. So people asking those questions, they're asking questions we don't have answers to. Nobody has these answers. There's no level of clinical specificity or sensitivity available yet. However, this is one of the things they're hoping to address, because, as I said, they're doing cross correlations with their molecular PCR testing and their antibody testing, so they can get a really good idea of what the clinical symptomatic picture can look like. Okay, ELISA kits come pre-packaged. They have all the enzymes and reagents, so one lab might use a different ELISA kit than another. Same problem the CDC had with their reagents. The reagent in one kit might not be as good. So you could even have and on the flip side, you could even have the best kits, but mess it up in the laboratory, right? So it's important that you have all of these things validated and, what did you say, the third party review for internal validation on your actual laboratory policies and procedures. So again, right now, where this stands, COVID-19 diagnostic lab testing is only going to be on respiratory samples, and it's primarily only going to be done through hospitals, right? Through clinics, not private clinicians like me. And they're going to be, he said metering, but I would say rationing, right? Like those out in a realistic time frame so they can turn results around. He said the swabs are starting to get in short supply, and the fact that the people collecting the samples need to be in full PPE to not contaminate the sample, again, plays an issue into this as well. So I can't get that kind of testing for you. We can do the PCR stool. We can drop ship those. My account with them was activated this morning. Like I said, I'm going to see if I want to stick with Great Plains in their antibody testing, or if I can get a straight answer from them on where their ELISA kits come from. Otherwise, I'm going to be going with diagnostics too. So I don't have information on pricing yet, but we keep learning, we keep evolving, we keep changing. So Initially, the antibody testing was really only being done with hospitals, their hospital clients, because they were doing it alongside the PCR testing, the molecular testing, mainly on staff, because they wanted to know who was safe to come to work and who wasn't. This is what gave them the best clinical information on when and how symptoms were present. So right now, he said the antibody testing is now available for private clinicians like myself. That's great news. Their ELISA kits come from the US. They're one of the best labs that he knows of. And there's a couple different ways that we can work with that. And his article is coming out the end of the month. So if you are someone who has access to the Townsend letter or the NDNR publication, he's going to have a lot more information than that. But that was a lot of information, right? I mean, yep, we're getting close. We got to wrap it up. Got a patient at 2. But I wanted to share that today because this is what's happening, right? You're going to start seeing on the news week after week, more labs coming out, more testing coming out. It's important to know what kind of testing you're getting, what kind of information that's actually giving you, if it's reliable, and what do you do with it, right? Where do you go from there? So a lot of food for thought today. I'm hoping to get some more information from Great Plains and from Diagnostic Solutions at some point today or tomorrow, and give you all an update on more testing options next week. So stay tuned, stay vigilant, and stay safe. All right, we'll see you all next week. Thanks for joining me.